Hey everybody, Dr. Ravich here from Vet Triage. It is Sunday, January 5th, 2025, 10:18 a.m. Pacific Time. We are going through this issue of veterinary surgery, and today we'll talk about the surgical management of brachiocephalic obstructive airway syndrome and update on options and outcomes. So this is not a research paper, this is a summary paper on the latest as of May 2024. So on the lower end there below me, you can see an example video of mine where I talk about this exact condition. So a lot of information that they are mentioning here, I'm not going to talk about. It's in my lecture. If you want more detail, I'm going to talk more about the highlights of things that are the newer data or things I didn't know about, and we'll be incorporating into future talks. But that's my talk from Zomedica. They sponsored it. Thank you to Zomedica, and it was in London Vet Show. So let's go over it. So this comes out of University of Georgia. And introduction: French Bulldogs are becoming the most popular breed in the United States in 2022, according to the American Kennel Club. There have been reproductive bans on English Bulldogs and Cavalier King Charles Spaniels in Norway, the end of registration of 12 brachiocephalic breeds by the Dutch Kennel Club, and recently legislation introduced in New Hampshire to ban the breeding and sale of brachiocephalic dogs. So right off the bat, this is a move I think in the right direction. These dogs are clearly, deformed. They have a whole host of medical issues, externally and internally. And although they come with fantastic personalities, they're a good sized pet. They're very cute. It is a move in the right direction. There are plenty of animals that need homes, and a lot of these dogs just they need lifetime of care for all their medical stuff, let alone all the normal dog stuff you have to take care of them for. Brachiocephalic dogs are known to have relative macroglossia, that's an enlarged tongue. It leads to dorsal displacement of the soft palate and further narrowing of the nasopharynx. Brachiocephalic dogs have a greater tongue volume related to body weight, skull length, and skull length/width ratio than mesaticephalic dogs. So mesaticephalic dogs are dogs that are normal shaped skulls. Additionally, this study found that the ratio of air to soft tissue was decreased by 60%, and the tongue was 10 times more dense in brachiocephalic dogs. Brachiocephalic dogs have significantly higher total tongue muscle and total tongue fat when normalized to body weight than mesaticephalic dogs, with more fat deposits in the caudal tongue in both groups. English Bulldogs, French Bulldogs, in comparison to pugs were found to have significantly smaller tongue volumes than the other two breeds. Brachiocephalics have a significantly larger esophageal hiatus. That's the opening where the esophagus goes down into the chest and crosses over into the abdomen through the diaphragm. That opening through the diaphragm is called the esophageal hiatus. And this increases the incidence of gastroesophageal reflux, regurgitation, and sliding hiatal hernias. Brachiocephalic dogs have a significantly shorter life expectancy compared to non-brachiocephalic, with a high proportion of deaths attributed to upper respiratory tract disorders. All right, second chapter, anesthetic considerations. Brachiocephalic dogs were 1.7 times more likely to have an intra-anesthetic complication and a 4.33 times more likely to have a post-anesthetic complication when compared to non-brachiocephalics. A longer duration of anesthesia increased peri-anesthetic complication risk overall in dogs in the study, whereas increasing body weight and having procedures performed by the orthopedics or radiology services decreased those risks. Considerations such as reducing the use of full mu opiates like morphine and having standardized anesthesia and postoperative protocols have been proposed to decrease risk of postoperative complications. Bilateral maxillary nerve blocks with lidocaine or levobupivacaine have been studied, show that significantly more dogs that did not receive the maxillary block required intraoperative fentanyl and intraoperative propofol or alpha-laxolone than dogs that did receive the maxillary block. There were no differences in need for postoperative analgesia between the two groups. There were similar intra and postoperative complications between the groups. Adding epinephrine to the maxillary nerve block can be considered, half receiving a block of lidocaine alone, and the other half of dogs receiving a combination of lidocaine and 0.00198% epinephrine. Total blood loss was significantly lower for dogs that had lidocaine and epinephrine into the maxillary block. Pre-oxygenating after pre-medicating administration and prior to induction has been performed. We perform pre-oxygenation for 3 minutes prior to anesthetic induction. It results in a significantly longer time to desaturation when compared to dogs that were breathing room air prior to induction. Pre-oxygenation is when you give the animal oxygen before you induce them for anesthesia. And desaturation means that the oxygen leaves the bloodstream into the lungs, or cells rather. Preoperative, increased time for upper airway evaluation and endotracheal intubation while also minimizing risk of desaturation are benefits of pre-oxygenating these dogs. Preoperative administration of metoclopramide and famotidine or a proton pump inhibitor can be considered. Dexamethasone sodium phosphate can be considered. Rate of postoperative regurgitation is significantly decreased in dogs having surgery after implementation of this protocol. However, there are no differences between groups regarding development of postoperative pneumonia or respiratory distress. Chapter 3, surgical options. 3.1, hyperplastic soft palate. Options include traditional cut and sew or sharp staphylectomy, carbon dioxide laser, monopolar electric cautery, bipolar vessel sealing device, air plasma device, harmonic scalpel, diode laser, plasma-mediated bipolar radiofrequency device. One study evaluating mortality after surgery between dogs undergoing staphylectomy with traditional method of cut and sew versus carbon dioxide laser versus bipolar vessel sealing device. They found the mortality rate prior to discharge from the hospital was 4%, and that dogs undergoing staphylectomy with a bipolar vessel sealing device had a significantly higher rate of perioperative mortality than dogs undergoing the procedure with the other two techniques. A higher grade of laryngeal collapse was also independently associated with perioperative mortality. In 2 other studies evaluating bipolar vessel sealing device or staphylectomy, there were no perioperative deaths out of 22 dogs, and there were 4 perioperative deaths in another study of 34 dogs. This is a picture showing 2 different methods of treating the hyperplastic trachea, the elongated soft palate. New techniques of staphylectomy have focused on ways to thin the palate while also shortening it or decreasing redundant tissue in the pharynx. The folded flap palatoplasty aims to address both length and thickness. The ventral mucosa of the palate, along with the palatinus muscle and part of the levator villi palatini muscle, are removed within a predetermined area of the soft palate, which decreases both the length and thickness of the palate. No intraoperative complications, but 11% of dogs required a temporary tracheostomy postoperatively, and 2 dogs did die in the perioperative period. In the dogs where follow-up was obtained, 97.5% had improvement of the respiratory signs, with the majority showing improvement within 15 days post-op. Another study showed pugs and French bulldogs that received the folded flap palatoplasty and wedge rhinoplasty. In this study, 9% required a temporary trach, and 2 out of 72 died. The thinning of the soft palate too much or leaving the folded flap too long could result in vascular compromise and palatal necrosis. Overall improvement of clinical signs, 88.5% in dogs after surgery. 25 dogs underwent the folded flap palatoplasty and had a reevaluation of their soft palate at least 28 days after surgery. Found wound dehiscence was present in 36% of dogs at a median of 36 days, with 2 patterns of wound dehiscence noted. In some, there was incisional dehiscence accompanied with caudal retraction of the palate. In others, a full thickness palate defect was present. Interestingly, half the cases with major wound dehiscence had no clinical signs. Retrospective studies showing 124 dogs undergoing the folded flap palate or standard staphylectomy. In this study, those undergoing the folded flap palate had longer surgery anesthesia durations, but there were no differences seen in anesthetic complications, less length of hospitalization, or post-op regurgitation. Major complications were rare. Comparing cut and sew staphylectomy and the folded flap palatoplasty in English bulldogs, used preoperative and 30-day post-op CT scans to compare palates along with oropharyngeal and nasopharyngeal air volumes. In that study, dogs undergoing the folded flap palatoplasty had longer soft palates post-op than dogs undergoing staphylectomy. No differences in post-op soft palate width, oropharyngeal air volume, or nasopharyngeal air volume was seen. 2 dogs in another study, also experienced dehiscence of the folded flap palatoplasty, requiring removal from that study. A split staphylectomy is another procedure. In this procedure, the palate is split down midline using a carbon dioxide laser to the desired length, and at the thickest point of the palate, the redundant palate tissue between the mucosal layers is removed using the laser, allowing for both shortening and thinning of the palate. Another study evaluated 75 dogs undergoing this procedure, found that major complications occurred in 2.7%, overall complication 8.3%. None of the complications were related to surgery and none were life-threatening. Of the owners that completed the follow-up questionnaire, 88% noted that surgery had improved their dog's quality of life. Another procedure is the pharyngoplasty, the goal of reducing pharyngeal obstruction through reduction of redundant pharyngeal mucosa, along with a staphylectomy and bilateral tonsillectomy. No dogs required revision surgery, and owner satisfaction was 97%. Overall mortality rate 2.6% within 2 weeks of surgery. Most of the deaths were caused by respiratory distress or upper airway obstruction. All right, section 3.2, stenotic nares. And here is a drawing, a picture of the stenotic nares, one option that we're going to talk about right now. Stenotic nares affects over 75% of dogs with nasal airway resistance from a combination of stenotic nares and nasal cavity obstruction, contributing to 80% of the airway resistance experienced by these dogs. The Trader's technique involves a partial amputation of the tissue cranioventral to the dorsolateral nasal cartilage. A study looking at this technique in Shih Tzus at a mean of 16 weeks of age showed improvement in these dogs. There's a dorsal offset rhinoplasty, which removes the alar cartilage, both caudally and dorsally. And in that study, showing 34 dogs, no major complications were noted in 85% of the dogs presented for a recheck examination at a median of 402 days. And then the procedure in the picture is a dorsal offset rhinoplasty, the one we just discussed. It was published by Dickerson et al. It involves the resection of a dorsal wedge from the nares with placement of the first suture, and then the remaining is simple interrupteds placed. And then, of course, you do it bilaterally. The ala vestibuloplasty has not been evaluated, but it's been described. An interesting study by another report compared 3 techniques for correction of stenotic nares using silicone models. They had 99 silicone models based on CT of a single French bulldog's nose. I don't know why you wouldn't go to 100 if you're already at 99. With one of the following procedures performed for each model: a vertical wedge resection, modified horizontal wedge resection, and an ala vestibuloplasty. Increased cross-sectional areas were found with all 3 procedures. The ala vestibuloplasty has a significantly larger cross-sectional area than the other techniques. That's what you want. You want a wider nares. Section 3.3, everted laryngeal saccules. There is some concern that laryngeal sacculectomy may result in increased post-operative complications. I would agree. A study evaluated this concept found that none of the everted saccules spontaneously resolved at the time of recheck evaluation. Because there's some question about whether or not you even should remove the saccules, and it looks like they're thinking maybe you should because they don't resolve on their own. Section 3.4, everted and or enlarged tonsils. There are no studies looking at the benefit of tonsillectomy undergoing surgical correction. The tonsils clamped off for 20 minutes and then excised using monopolar electrosurgery. Unfortunately, 11 out of 39 dogs had complications, most of which resulted in bleeding, either intra-op or post-operatively. You can use a bipolar vessel sealing device for tonsillectomy, which is what I've used. Another study looked at dogs undergoing comparing a bipolar vessel sealing device to a technique involving the use of a tonsillectomy clamp, sharp transection and closure of the tonsillar crypt with a Parker-Kerr oversew pattern. Less hemorrhage and faster surgery with the bipolar vessel sealing device when compared to standard technique. Damage to the tonsillar tissue was evaluated by histopathology, showing 1 to 2 millimeter of coagulation necrosis at the edge of the tonsils removed with the bipolar vessel sealing device. This is less tissue damage than noted by another study using a bipolar vessel sealing device for tonsillectomy, where the damage is 3.4 millimeters. Section 3.5, aberrant nasal turbinates. These aberrant nasal turbinates are postulated to lead to decreased nasal airflow and increased nasal mucosal contact points. You can use a diode laser under rhinoscopic visualization. This is known as the LATE procedure, L-A-T-E. Main complication with LATE procedure is intraoperative hemorrhage that's usually self-limiting. In another study, regrowth of the turbinates 6 months after removal, causing potential reobstruction and need for a second removal, occurred in 15.8% of dogs. Dogs with a brachiocephalic index of over 50% and those with a functional grade of 2 to 3 at the postoperative follow-up were considered candidates for the LATE procedure. Using that criteria, 29 out of 57 dogs were candidates for the procedure, with all of those dogs being pugs or French bulldogs. And the dogs that underwent the LATE procedure, there was a significant improvement in their brachiocephalic index when compared pre and post procedure. The amount of soft tissue present at the rostral end of the choana, as measured on CT scan, was a predictor of dogs that would benefit from LATE procedure in pugs and French bulldogs. All right, section 4, postoperative management. Respiratory complications were noted in 23.4%, overall mortality 2.4%. Risk factors include older age, presence of airway pathology that's not primary, so things like laryngeal collapse and tracheal collapse, presenting as an emergency, with the odds of developing a complication being over 30 times higher if they present for an emergency. Younger dogs were more likely to experience regurgitation in the postoperative period, with odds of postoperative regurg occurring in 28.8% for every 1 year increase in age. Dogs with a history of regurgitation prior to surgery were also more likely to experience regurgitation postoperatively. Short-term complications after surgery found a major complication rate of 7%, and the only factor that was found to be associated with major complications was postoperative radiographic evidence of pneumonia, with age not being identified as a risk factor. Overall respiratory compromise of 15%, and the only risk factor associated with respiratory complications were associated with the need for tracheostomy post-operatively and were increasing brachiocephalic grade and the presence of pre- and post-operative aspiration pneumonia. Dogs were discharged within a few hours after surgery once they were able to walk around the room and breathe normally. The other group of dogs in this study had a standard post-operative recovery without the owner present and were hospitalized for at least 24 hours. Dogs that underwent standard recovery had significantly higher rate of complications at 28%, compared with dogs undergoing owner-assisted recovery, complication rate of 2%. Additionally, none of the dogs in the owner-assisted group required additional veterinary assistance after discharge. That's pretty crazy. You can also look at nebulized epinephrine pre- and post-operatively in a study where 0.0 mg per kg of epinephrine was diluted in 0.9% saline. A significant decrease in brachiocephalic index was noted pre- and post-op in this population of dogs. 5 dogs in the study did not tolerate nebulization, and nausea was noted in 4 dogs. Another larger study evaluated 0.5 milligrams of epinephrine, so not 0.5 mg per kg, but 0.5 milligrams total. Sorry, the other study was 0.05 mg per kg, and this one is 0.5. And they diluted it in 4 mils of saline nebulized to patients that were experiencing stridor or dyspnea after surgery. They found that 4 out of 90 were agitated after nebulization, and there was no significant difference in heart rate or respiratory rate 60 minutes after nebulization. You can also consider high flow oxygen therapy using specific nasal cannula system where very high oxygen flow rates are administered prior to intubation and ventilation. None of these dogs required reintubation. All were discharged from the hospital. One dog experienced aerophagia that required orogastric intubation. This modality is very promising when needed during recovery from general anesthesia for any reason. Heliox, which is a mixture of helium and oxygen, has been used to improve airflow and reduce airway obstruction in people. In a study, Heliox was administered in healthy mesocephalic and brachiocephalic dogs with tidal breathing flow volume loops recorded and compared to those obtained when the dogs were breathing room air. It was found that in brachiocephalic dogs, peak inspiratory and expiratory flow were significantly increased when Heliox was administered. You can also consider nasotracheal intubation, which bypasses the upper airway that can occur postoperatively in upper airway obstruction that can occur postoperatively. With this technique, you take a 5 to 10 French tube, insert it through the nares, exteriorize it through the oral cavity, and then the patient is extubated and the tube is inserted into the trachea at the level of the thoracic inlet. Oxygen flow is delivered through this tube. No dogs with nasotracheal tube experience respiratory distress postoperatively in comparison to those without nasotracheal tubes. When evaluating risk factors for dogs that required a postoperative temporary tracheostomy, they identified a 30% increased odds of needing a temporary trach for each 1 year increase in age, further highlighting the importance of early surgery. Placement of temporary trach often results in positive outcomes, with 40 out of 42 surviving to discharge and no long-term complications. Temporary trach was placed for a median of 2 days, with the tube remained in place for up to 7 days in some patients. Permanent tracheostomy is also necessary for some dogs, typically those diagnosed with grade 3 laryngeal collapse. Another study found that brachycephalic dogs were significantly more likely to require revision surgery after having a permanent trach as compared to non-brachycephalic dogs. In another study, 8 died during secondary to major complications, with major complications occurring in 80% of dogs. Long-term survival over 5 years after surgery with a good quality of life was seen in 5 out of 15. Yikes. Okay, section 5, last section here, outcome. Evaluating outcome at 6 weeks after surgery, it was noted that almost 71% of dogs showed improvement in respiratory signs, with the only factors associated with improvement being the severity of inspiratory effort, pre-op and preoperative Poncet score, that's P-O-N-C-E-T. A study evaluated dogs 1 to 6 months after surgery, found the median brachycephalic index decreased after surgery through the median postoperative brachycephalic index was still in the clinically affected range. In this study, younger age, a normal body condition score, and the presence of laryngeal collapse were all negative prognostic factors after surgical treatment. Additionally, modified multi-level surgery consisting of an ala vestibuloplasty, modified folded flap palatoplasty, removal of everted saccules when indicated, and removal of everted tonsils when indicated, plus a partial cuneiformectomy in dogs with grade 2 or 3 laryngeal collapse was found to be associated with a positive outcome more often than traditional multi-level surgery, which is cut and sew staphylectomy, vertical wedge resection, removal of everted saccules when indicated, and removal of everted tonsils. Keep in mind, though, by the way, when you look at this is grade 2 to 3 laryngeal collapse, which is severe. So these are dogs that are going to die, because I would never perform a partial cuneiformectomy unless it was like a Hail Mary. Nasopharyngeal collapse is also seen in some dogs. This is evaluated by fluoroscopy. A study found that dogs with brachycephalic syndrome had a significantly higher reduction in dorsal-ventral dimensions, so like this, dorsal-ventral, of the pharynx during respiration when compared to control dogs. No significant improvement was noted in this measurement after surgery in the brachycephalic dogs, though if more dogs had been evaluated, a difference may have been seen. Interestingly, nasopharyngeal collapse with a pharyngeal diameter change of greater than 50% has been documented using fluoroscopy in a small percentage of normal beagles without evidence of cardiopulmonary disease, indicating that visualization of collapse on imaging may not correlate to clinical disease. And beagles are considered brachycephalic dogs, although, we don't really we don't really see them for the syndrome. So I don't know if using beagles is a great example, but so be it. Another study compared dogs that had undergone anesthesia before and after surgery and compared complication rates. Dogs that had undergone surgery had a 79% increase odds of having a post-anesthetic complication at subsequent anesthetic events. So if they had anesthesia for this surgery, then subsequent anesthetic episodes are less risky for them. And that makes sense because you're fixing the problem, and that problem is respiratory in nature. My only two comments with this paper is I wish they went more into the gastrointestinal part of this disease, because I think that's severely underlooked in our profession. And I also wish we go over cats more. There are brachiocephalic cats. There are doctors out there that do cut these cats, and we often overlook it because it's not as common as dogs, but it is one that we should tackle with further research. All right, thanks guys. Please follow and subscribe and like and share. We'll see you guys again tomorrow. Thanks for the support. Bye.